Welcome back to the One Thing podcast. Today, we're joined by someone whose career spans nearly every corner of modern medicine, from the chaos of the emergency room to the emerging science of precision detox and immune restoration. Dr. Pamela Smith has been practicing medicine for 48 years, beginning as a emergency room physician at Detroit Receiving Hospital, a level 1 trauma care center. She was there before Narcan became part of emergency medicine. And in those early days, she saw firsthand how therapeutic plasma exchange could be used to remove life threatening toxins from the body. After 2 decades in emergency medicine, Dr. Smith transitioned into what would become her life's work, personalized and functional medicine, where she spent nearly 30 years looking at root cause of illness rather than treating symptoms. Today, she blends her backgrounds in toxicology, hormones, immunology, and environmental medicine to pioneer new ways of helping patients with complex chronic conditions, including autoimmune disease, cognitive decline, cardiovascular issues, mold toxicity, persistent viral load, and more. In fact, she and her longtime colleague, Dr. Paul Savage, have now completed over 500 therapeutic plasma exchange treatments using protocols they've developed and patented, combining TPE with nutrients, peptides, exosomes, and glutathione to help the body remove environmental toxins that standard detox approaches simply can't reach. Dr. Smith is also the author of 14 books, including What You Must Know About Women's Hormones, Maximize Your Male Hormones, and her newest bestseller, How to Prevent Breast Cancer Before and After. She teaches internationally and has become a trusted educator to both clinicians and patients looking for a deeper, evidence-informed path towards health. In this conversation, we explore the real science and the real controversies behind therapeutic plasma exchange, including what actually happens to the immune system during a session, why TPE alone isn't enough for toxin removal, how antigen load influences chronic inflammation and autoimmunity, why patients don't tolerate hormone therapy until toxins are removed, how TPE is being used in autoimmune disease, cardiovascular disease, long COVID, mold illness, and cognitive decline, and also how Dr. Smith discerns legitimate medical use from wellness world hype. We also talk about her remarkable personal story, including a near-death experience that completely reshaped her understanding of the gut and its role in long-term health. This is a nuanced, grounded, and hopeful conversation with a physician who has seen almost everything medicine has to offer and is still learning, still listening, and still pushing the field forward. So with that, I welcome you to the next episode of the One Thing podcast. Thanks for being here. Dr. Smith, welcome to the One Thing podcast. It's a delight to be here with you today.
Oh, I love being here. Thank you so much.
You're welcome. It's great getting to know you a little bit and realizing we know some people in common. The late, great Dr. Walter Crinian, who's influenced so many people in our profession, and Dr. Paul Anderson, who's a big mentor for a number of us. So it's great to know that you're part of the same group or family, kind of extended family.
It is an extended family.
So today we're going to talk about therapeutic plasma exchange specifically. That's like the main topic that I wanted to speak with you about. I know you're an expert in that, and I'd love to start off hearing what led you to explore the use of TPE for patients. When did that begin in your career trajectory?
Well, I was an ER doctor at Detroit Receiving Hospital, level 1 trauma center for many years. And this is my 48th year of practice. So I am old enough that I was around before Narcan. So yes, there was life before Narcan. So when someone came in with a drug overdose in the ER, we used therapeutic plasma exchange to get rid of whatever toxin there may be. So TPE has been around for over 50 years. So we've been using it long term for many different things.
Okay, so you were using it more in an acute setting. And
Absolutely.
did was there a gap in the use of it and when you started to use it in settings that you're using it now? Like, how did that bridge happen? Was it you moved away from ER work and then brought it back into your practice, or how did bridge the gap between today and those early days?
Really, it happened, it's probably been it's just shy of 30 years now where I've been doing a personalized medicine approach with patients. So I spent some time bridging the time between ER and a personalized medicine practice, but I had a practice for a long time, looking at the cause of the problem and not just treating symptoms, which I think is grand. And then about 4 years ago, I read Kiprof's article looking at therapeutic plasma exchange for longevity. I'm not sure personally what longevity means
Yeah.
from the viewpoint because it's kind of hard to measure if you're fixing longevity or increasing it. And to me, I want to live to be a healthy 100, but
Mhm.
I want to be healthy and not just live to be 100 years of age. And
Yeah.
so I read Kiprof's article, and then Dr. Paul Savage called me, who I go back to the ER with. So we've been working together for just under 40 years on different areas being healthy, shall we say, from a functional medicine approach. And showed me Kiprof's article, and I thought, this is really interesting. I have a master's in public health and toxicology. So we started going down a road of maybe we could do this to really remove toxins in the body. Because what we were doing was getting rid of inflammation. A small amount of inflammation heals. Inflammation otherwise causes disease.
Mhm.
So, probably starting at the age of 42 or maybe even before for some people, they're really inflamed, and that's what's causing the disease process. So, how do you get rid of inflammation? I mean, that's heart disease, that's cognitive decline, that's autoimmune diseases, that's cancer, that's eczema. I mean, you can take it into many different realms. How do you really get rid of inflammation? And so Dr. Savage and I started going down a road of doing therapeutic plasma exchange, but we discovered that TPE by itself does not work for getting rid of the toxins because we were doing toxin tests before, after each exchange, and then at the end. And we discovered that we had to give nutrients. For some patients, we had to do stem cells. We may have to do exosomes. We may have to give IV glutathione and other things, that it took more than TPE to actually rid the body of different toxins. Whether you were talking about endocrine disruptors like BPAs and phthalates, or you were talking about mold or toxic mold syndrome, whether you were talking about metals that were toxic like lead, mercury, cadmium. We now actually can get rid of aluminum, gadolinium, different kinds of metals we couldn't get rid of before. So we could get rid of forever pesticides, and they're called forever chemicals for a reason because we could get rid of them. We are now able through TPE with protocols that we have patented, looking at adding other things, and we can get rid of toxins because we're doing before and after testing.
That's profound. There's, I think, people who are accustomed or have learned about detoxification protocols realize that these toxins don't just hang out in the plasma, right? They're distributed throughout the body. So it makes sense that you would have to get them to the place where you could remove them from the system. So it's really interesting to hear the foundational practices in environmental medicine as a platform, and then the TPE being something that's taken it to, a more profound level. Does that encapsulate sort of how it built into the sort of the systematic approach that you take? Was it building on other principles?
It was building on other principles. So we found some interesting things. We actually had my best friend who is a pharmacist who had a heart attack and acute MI. And he was young when he had it. And basically, he had plaquing or hardening of the arteries. And so he'd had his a stent and other things done. But how do you actually reverse plaquing? There's
Yeah.
only two things that have been shown to reverse plaquing before now. Pomegranate juice, of which, believe me, I do drink 2 to 4 ounces every single day of my life of pomegranate juice. And for women, estrogen replacement, and for men, testosterone replacement, done correctly, okay, both of those low dose do actually remove plaquing. So he wanted to look at the idea, could we remove plaquing by doing TPE? So he was our first patient. And we did discover now we've done enough patients because we've done over 500 people that you can actually also reverse plaquing with therapeutic plasma exchange with the addition of nutrients, exosomes, stem cells, etc. Then we thought, well, what else can you look at? And we decided to look at cognition. I've written 14 books, and one of them is on memory. And we've done many things in life to try and prevent Alzheimer's. What can you do for people with mild cognitive impairment, et cetera? Well, it's all inflammation. And we discovered that a lot of people that are having issues with mild memory loss, et cetera, really were having brain fog secondary to toxins.
Mhm.
When you did TPE, you could help neutralize some of that for some patients. That doesn't mean it's a cure for Alzheimer's disease.
Sure.
What it means is we want to try and prevent some of this by getting rid of the toxins early.
Sure.
Then we looked at autoimmune diseases. I happen to specialize a lot in natural hormone replacement. And so one of the autoimmune diseases I wanted to look at was PCOS,
Okay.
because PCOS is an autoimmune disease. And we discovered that whether we were looking at Hashimoto's or PCOS or Crohn's disease or long haul COVID or whatever, that because it was an inflammatory process and the body was attacking itself and changing its immune system, the T cells in some cases, it was really because of the inflammatory process that was going on. So when we got rid of the toxins, it could help. In fact, I personally had 4 patients who could not use hormone replacement therapy. It didn't matter how little progesterone you gave them, they really couldn't take it because they were too toxic. We removed the toxins, then we were able to help the patient now be able to have hormone replacement, male or female, in a fashion that they could. So we've looked at it from many different aspects, including people with precancerous cells, et cetera.
Interesting. Yeah, I want to circle back at those to ask you a question about those patients that don't tolerate hormone replacement therapy. That's very interesting. Another interesting thing that you said that I've never actually heard anybody frame in this way is that PCOS is an autoimmune condition. Maybe you could just give us a comment or two on how you see that, because that's not something that I think is commonly mentioned.
It's not. Where it's just recently in the medical literature now where the body seems to be attacking itself, which is what an autoimmune disease is, with PCOS. It used to be called Stein-Leventhal syndrome
Right.
when I was in medical school. So granted, that was 50 years ago,
Yeah.
but I was told that I would see 4 cases in my whole life.
Oh, wow.
My whole life. I see 10 cases a week, just me.
Yeah.
Well, it is a very common disorder in young women. The reason it's so important to look at is because PCOS not just increases the risk of infertility, which is a big deal, but women with PCOS tend to have insulin resistance. It doesn't work as effectively as it should, which is probably an autoimmune dysfunction. Those same women have an increased risk in breast cancer, ovarian cancer, uterine cancer. They tend to have methylation processes that don't work, which increases their risk of other diseases as well. They tend to be inflamed. Their C-reactive protein, an inflammatory marker, is high. All of that we know when they're 18 or 20 years of age.
Mhm.
So we can go back and relook at PCOS in a different fashion. Conventionally in medicine, we give birth control pills. I would love to look at the cause of the problem and try looking at different things, which we are successful at. They have high testosterone and lowering it with herbal therapy. in giving progesterone if needed, because many of those women do tend to be low in progesterone. And now looking at the autoimmune process, of which we do 4 things for. And I'm sure you've discussed this on your podcast when looking at autoimmune diseases. But number 1, we take the patient off of gluten. Number 2, we fix their gut. So we do a gut health test on everybody who has any autoimmune disease. Number 3, we start them on low dose naltrexone, which decreases inflammation in the body. And low dose, we use that as a compounded product. And now we do therapeutic plasma exchange to get rid of those toxins. Because when you do a toxin test and look at 109 toxins, they are much more high than other people are.
Yeah. As the number one cause of infertility, it's such a emotionally challenging condition to deal with. And I'm sure, the options of looking at toxin clearance and gut healing and inflammation balancing and hormone balancing is much more comprehensive than what they would typically be offered in a standard OB/GYN visit.
Yeah, so it's just a different way of looking at cause.
Wow. So this is really interesting. And I do want to come back to that comment about patients who don't tolerate hormone replacement therapy, because that reminds me of a conversation I had with Paul Anderson once, Dr. Paul Anderson. So, and maybe we'll get to that in a second, but I would like to back out a little bit and share with those people who are wondering, trying to visualize what is happening in a therapeutic plasma exchange session, from the setup to what actually the mechanism of it is. Maybe if you could just give us some basics of that.
Absolutely. It's actually an easy procedure. Okay. So for the women out there who've had 5 children, I have lots of kids. Okay. And you may have bladder dysfunction. The hardest thing for TPE for some people is that really it's best if you sit still for the entire 4 hours, because you do have an IV in each arm. We do not miss at MD Lifespan because it's done under ultrasound guidance. And so they're put in, and in one arm, we take out the plasma. And in traditional plasmapheresis, they would clean some of it, put it back in, or they would separate out the plasma from the red blood cells, white blood cells, etc., clean it and put it back in. And what we're talking about here is we take out the plasma and we put back in albumin, which is a protein that the body makes. So that way we have less possible reactions or side effects with people. But you basically sit in a chair with an IV in each arm for 3 hours for the plasmapheresis and about another hour for the IV nutrients. That's really the procedure. You can read a book, you can sit there and watch Netflix or whatever on television. You just really kind of have to sit still. That's the biggest deal.
Okay. The elements that you're putting back in is the IV nutrients, because without them, there might be a depletion of these nutrients, or is it to make the therapy work better?
Both. And that's a really good question. Thank you for asking that. Because what happens is when you have the plasmapheresis of the TPE, it takes out your nutrients. It also takes out your medicine. So anything you may have taken that morning, if you have blood pressure medicine on board, it will leave with the plasmapheresis. So all of that goes out the door. We put albumin back in. And so we like to replenish things with an IV so that the patient leaves with all their potassium, magnesium, and everything else back on board.
Okay. And what is albumin doing? Why are you using that as a protein or chemical to put in? What is that? What is the function of albumin? And has that always been what's used in TPE, or is that something that's evolved as part of the therapy?
That's evolved. Back early on when TPE came about, they basically took out the plasma, separated it from the red blood cells, white blood cells, and put everything else back in. There was a 25% reaction rate. And doing albumin and putting it back in, it really isn't that. The reaction rate is very small. We've had about 4 or 5 people get a little dizzy. We had one person pass out, but it was because they actually told us they ate breakfast and they didn't.
Yeah.
People do have to eat breakfast before they come, and their breakfast was coffee.
Okay.
Okay. So we may have some people get a little bit dizzy. And people like me that don't weigh a lot, my plasma exchange is half of an exchange because I'm right at 130. 30 is basically, if you weigh less than that, you can only do half an exchange because it's too much of your fluid coming out of the body. So we do half of an exchange.
Okay. And I know of albumin as critical part of protein signaling or carrying hormones and carrying molecules throughout the body. Can you talk about what its role is in TPE specifically?
And part of it is it's a placeholder. It puts the volume back in so that people are dizzy or having intense fatigue when they leave. It also is, as you pointed out, most of the hormones in the body are actually, particularly for men, they're attached to albumin, and that's how they're carried into the system. So that's part of testosterone is attached to albumin and sex hormone binding globulin. So a hormone has to be put on some sort of receptor to stay in the body.
Interesting. Okay. So when you're working with your patients, how do you select who is an appropriate candidate for TPA? What's the flow of that recommendation? Is it everybody is that you're working with these days because of your patient population fits? Or is there sort of a algorithm or something you see on your workup and testing and history that makes you select this therapy?
Well, what we do, honestly, is personalized medicine. It is care because that's where medicine is now. We do have the science to offer personalized care to everyone. But you're right. There are some people who are not candidates. Okay. If your kidney function is not very good, you may not be a candidate because albumin, you have to be able to put it back in, and that does go through the kidneys. If you just had a heart attack, you would not be a candidate. We would wait 6 months to a year before you would have it done. If you just had a knee replacement or other kind of surgery, then we would wait at least 90 days before you had it done. So we do a very selective intake process to look at whether people are candidates or not for the procedure. At MD Lifespan, we do only adults, so not children. So children are really
Yeah.
not something we do at this time.
Okay. I'd like to dive into more about the immunology and maybe some of the toxin work that you're doing. So I know in other talks that I've seen you give, talking about TPE reducing antigen load, and we were talking before we got online about COVID and long COVID and long Lyme, and I'd love to hear, just for people who don't understand the concept, is that like how reducing antigen load helps these patients. I mean, it seems obvious to people who maybe have gone to medical school and what have you, but I think people need to hear like how difficult it is to remove antigen in the first place. And then is this therapy successful at removing antigen, and how does that restore health in patients?
I think what people sometimes don't realize is when they get some viruses like Epstein-Barr virus, which 98% of the people in the United States have had, you carry that antigen forever.
Right.
So people have it lifelong. So if you had it when you were 16 and I draw your blood, I will see that you actually are positive that you had Epstein-Barr or when you were 16 years of age. So there are a number of viruses that the antigen stays up and does not go down when the disease is gone. And so it's part of how we develop vaccines and other things for people. So when you get something like COVID, for example, then you end up with an antigen response, antibody response, and antigen. We've really never been able to lower that response because we want your immune system to go back to normal after you've had COVID, after you've had mono, whatever we're talking about, after you've had shingles. We want your immune system to go back to normal and not stay in a hyperimmune state. A hyperimmune state is really how you get an autoimmune disease process. So we want the T cells, which are produced by your body, to go back to their normal regulation. So you have Th1 cells and Th2. You want them to go back to being balanced and not one side be higher than the other. When we do therapeutic plasma exchange, we have discovered that it does allow the immune system to go back to its balanced state that it may not have been when you had Lyme or COVID or Epstein-Barr, et cetera.
Okay. So specifically, like the immune system that's hanging out in the plasma, maybe being upregulated prior to the session or as you approach the session, how would we quantify what happens to Treg cells and antigen presenting cells and various immune mediators? How do those shift during a session? Is it profound where you can actually see measurable change, or does it take multiple sessions to really make a difference?
That's a really great question. So, first of all, your immune system does dysfunction. It becomes imbalanced in many different disease states. So, when we go back and we look at how it now becomes balanced, that is the key component of really what happens. But that has to do with inflammation because it's not just the Treg cells that are involved. Then cytokines become produced, and you end up with a cytokine response. And nobody ever heard of that word until COVID. And the people who got really sick with COVID had a cytokine response. All of that goes back to normal as well. It's not just the T lymphocytes that go back to normal. It is also the cytokine response, and all of that returns to normal as well.
Basically, if you're to take what the samples of what is exchanged out and you would put those through testing and measure those mediators, you would see sort of like this shift in a session where you're dumping cytokines, you're dumping immune cells that are upregulated and kind of restoring balance. Is that what you're saying?
Yes, and we can now measure all of that. So it used to be that we could just look at the basic immune system where we looked at IgG, IgM, IgE, which is more of an allergic response, etc. That was basic immunology 30 years ago. Now we can measure the T lymphocytes. Now we can measure the cytokines. We can actually, that is all available at any basic lab now. So we look at a before and after TPE, and we can see the change. To answer the rest of your question, really no one does well after only one TPE. I wish it were the case. Life would be so simple if that's the way it was. But what we are doing is 1 or 2 sessions for women who are planning to get pregnant, because all these toxins go through the placenta, they go through the breast milk. A healthy mother produces a healthy child. That's how it works. Because the incidence of ADD, autism, and all of that has just gone up dramatically, very much probably related to toxins and other things, of course. Have a healthy mother, those people usually have 1 or 2 sessions. But people who already have a disease process or looking at prevention of a disease process, the average person needs 3 to 5 sessions because the first 1 or 2 or maybe 3, it's getting it out of the plasma, still in the tissue. In fact, after about the 3rd session for most people, you actually see the lab get worse. Because it's leaving the tissue and going into the bloodstream again, the plasma. And we actually see the numbers go up. For the people who are really sick, we may need 5. I had one patient who needed 8 sessions. They got out in 3 sessions what was in the blood, but it took 8 sessions to get out what was in the tissue itself. That out too.
Okay. Yeah. I mean, I think that's a very common pattern in environmental medicine and this type of work, or where you start pulling from the body and you see these elevations before you get to the other side of things. Are people feeling pretty sick in those moments when they're going through this, or Are they feeling any different than they did when they walked in?
I think the biggest thing people feel the next day is fatigue, just because they're waiting for their own red blood cells and things to pick back up again, will regenerate a lot of this itself.
Mhm.
So the next day, most people feel tired. So
Mhm.
I never recommend people go to work the next day. After that, almost everybody feels better. Now, if you were really sick and you had, for example, many molds, then you may feel worse. You may have muscle aches and pains for a little bit of time. And those are the people that we use exosomes and things and give them glutathione, et cetera, to try and minimize that from happening.
Okay. So there's part of me that wants to ask a few questions that come to mind that are concerning. And I think I'll go into one of them. One is, when a person has gone through this session, does it make them more susceptible to infections like common colds, viruses, other viruses that they might have while they're recovering?
Actually, no. We thought that might happen, that there may be a dysregulation of the immune system for a short period of time. As long as you give the nutrients afterward, we are not seeing it. So we're not seeing people get sick when they get on an airplane. If they came to see us and they go home on an airplane, are they getting sick because the person next to them had COVID? Not really.
Okay.
We're not seeing a dysregulation of the immune system at all.
Okay. Yeah. I think it's interesting because with biologic medicine, which is what a lot of people with autoimmune are given, they're even getting more specific with which cytokines those medications are targeting, getting down to the point that they're targeting either one or two knockdowns of the immune system, and versus before they were broad spectrum. So I'm just curious, like, compared to immune risk when people have an infusion of a biologic, it sounds to me this is even less risky, but I'd love to hear your comments on that.
There really isn't any risk to like a biologic would have. And that doesn't mean I don't write prescriptions for biologics. I do. There are
Yeah.
some people who need them and they do very well on them, who have psoriatic arthritis or disease processes of that nature.
Mhm.
However, that doesn't mean I still don't fix their gut, have them take off of gluten, take LDN and suggest TPE, or at least look at the toxins that they have. There's really no risk to the immune system not working. It actually works better when the toxins are off. It
Mhm.
allows the immune system to re-regulate itself and fix itself, which
Mhm.
is a wonderful thing. We want the body to fix itself.
Yeah. So I'm going to lean in on something that you keep bringing up, and it seems like it's a really strong reason why you do this therapy, and that's its impact on inflammation and stabilizing inflammation. And when you're saying that, inflammation is a pretty broad term, but are you talking about the things that people commonly know,